Our next speaker is a colleague of mine at Manchester Royal Infirmary. He's worked with me on our TOE course, which has run for a number of years now, Dr. Martin Bewsher.
Good morning and welcome to Manchester, the world capital of football for the moment. And thank you very much indeed to Niall and Donna for asking me to come and talk at this meeting. Can you hear me okay? Yep. Okay. Righto. The gentleman on my right, anybody know who that is? Anybody recognize him?
He's got more hair.
It is. It's George II, who was in fact the last overseas-born monarch of Great Britain. He was known as a bit of a tyrant, a bit boorish, short-tempered. Some said at the time, perhaps the prototype cardiac surgeon. Unfortunately for him, in the 1760s, he didn't know that he had an aortic aneurysm at that time. Clearly, there was no helical CT, no transoesophageal echo in 2D or 3D. And one morning, he got up, went off to the loo, as he did routinely at 6 o'clock in the morning, and he sat there and did what he does, and his aneurysm dissected. The post-mortem of George II is actually, you can find online, and for a boring Sunday afternoon, nothing else to do, it provides some interesting 20 minutes worth of reading. But that brings us on to our next chap, perhaps a little bit more recognizable. That is, in fact, Michael DeBakey, pioneering cardiac surgeon who came up with a classification for aortic dissection, and unfortunately, just before his 98th birthday, dissected himself. And whilst he became comatose in hospital and had instructed medical staff that he was not to have surgery, his family intervened and he ended up having his dissection repaired and left hospital, limped out in a wheelchair 2 months later. So I guess the take-home message from this slide is that next time you see a 98-year-old who's comatose with a type A dissection, crack on, don't worry, they'll be just fine. But he did provide us with the classification, a classification. On the far left, we have the type 1, which involves the entire aorta from ascending through the arch into descending. The type 2, which involves just the ascending. And on the far right, we have the type 3, 3A, which is above the diaphragm, 3B, which passes beyond the diaphragm. The Stanford classification is probably used a little bit more often. It's a bit more relevant. Basically, an A you operate on, B you don't. A involves the ascending, B does not involve the ascending. Stanford is the one which is usually quoted these days. But in any patient who has a dissection, a timely diagnosis is what is key. We know that the mortality is increasing by the hour. And the diagnosis is not always entirely obvious. They don't all come in with central tearing chest pain going through to the back with a pulse deficit and having a bit of a stroke, unfortunately. A high index of suspicion is required to choose an imaging modality which is going to find you that intimal flap as quickly as you can. Now, these numbers are from the International Registry on Aortic Dissection back in 2000, and I think they probably reflect what is still going on, at least in this country today. And you'll see that both CT and echocardiography provide the majority of both first mode of investigation, of imaging, and second mode as well. Aortography, which had been the previous gold standard, really has been surpassed. It is certainly less sensitive than the other modes. MR with sensitivity and specificity of 99 to 100% is excellent, but we haven't all got access to that 24 hours a day, that's for sure. And CT scanning in the older literature had slightly lower sensitivity, sort of mid-80s to 90, but with modern multi-detector helical CT scanning, sensitivity is 99 to 100%, specificity also of 99%. Which brings us on to echocardiography. Transthoracic imaging is something which can be done within seconds. Patient comes in, high index of suspicion with chest pain, probe is put on the chest, you can make that diagnosis with a parasternal long axis view, a good view of the aortic root. There's your flap, diagnosis made. Sensitivity is, however, a little bit less, but I think it's so easy to do in somebody. It's something that should be the first mode. And this is backed up by the American Heart Association, the American Association of Thoracic Surgeons, with the SCA as well, would condone that. TOE 20 years ago, very sensitive, but specificity lacking at that time. That was probably due to poorer technology, and in particular because of biplane imaging as opposed to modern multiplane imaging. And now we're looking at sensitivities and specificities, which is right up there with CT scanning. We know about the blind spots and we know about the artifacts, and I'll come on to just say a little bit about the artifacts, but they're usually very obvious, and they usually fulfill criteria, which if looked at, you can easily spot an artifact from a true intimal flap. What centres tend to do tends to be determined by how the patient is and by an institutional arrangement, what is available after that initial transthoracic scan. Most people who are stable will go for a CT, multi-detector CT. In the unstable patient, that is probably just an imaging mode too far. And it would be recommended that after a transthoracic imaging in somebody who is either positive for a type A or with a high index suspicion should go for transoesophageal echo at that time. Now that's not without its difficulties. If there's anybody in the room who's actually done a TOE in an awake patient who's got an assumed, a possible type A dissection, as yet there are not even anecdotes of patients actually having died on the end of a TOE scope. One cough, dissects, ruptures, dies. I do know of one which died some 10 minutes after a TOE. And certainly what the North Americans, their guidance says that patients should actually be intubated, should have a formal anesthetic and be intubated rather than being done under sedation. So the way you go about it will be very much determined by your institution and by how your patient is, how stable your patient is. Somebody who's clearly unstable, you're not going to spend the next hour wheeling along to a CT scan. So when we do our imaging modality, whatever that is, we first of all want to confirm the diagnosis. This is obviously a long axis view of an aortic valve, an aortic root, and there is the flap, which is moving out of synchrony with the aortic walls. It's very obviously an aortic intimal flap. Diagnosis is made. That's a long axis view, and in the short axis, that is the sort of view that we get. This will take seconds to do that. So that is an acute type A dissection. Equally, what we may see is an intramural hematoma. Long axis view in the top left there, where you see the hematoma extending downwards into the sinotubular junction. Short axis below that, and you see that it actually has this lunar eccentric shape, which is actually impinging on the lumen of the aorta. These aren't classical images. You can't actually see the intima overriding that, unfortunately, on these images. But that is one way to be sure that this is not just thrombus formation within the aorta compared to an intramural hematoma. What you may also see in intramural hematoma, which accounts for about 15 to 20% of acute aortic syndromes, what you may also see is echolucency within that hematoma, just pools of blood. And the natural history for intramural hematoma is about 10% will actually regress, patient survives. These would be considered in the ascending aorta. They should be managed in the same way as a type A dissection and go straight to theatre. They can go on to dissect, and they can actually rupture as well, where the intramural hematoma actually moves inwards and dissects or actually bursts outwards, causing your rupture. The third view, I'm not sure how well that is projected, but that has actually shown an intimal flap at the end of a hematoma. And some people would state that the intramural hematoma is actually the first stage towards a dissection. So, having there we think we have our diagnosis, be absolutely clear that we have not got an artifact. Unfortunately, I haven't got a good video to show you of artifacts within the ascending aorta. But they are well described. There's plenty of literature out there and has been for some time. On the left, long axis view of the aortic root. And we have a reverberation artifact, clearly arrowed there. And that is caused by reverberation between the transducer face and the anterior border of the left atrium sat behind the aorta. Equally, it could be slightly higher. It could be the right PA, which will do exactly the same and produce that linear artifact. On the right-hand side, we have at the isthmus of the aorta, we have a very wide artifact at the point where you frequently will see a transection in deceleration injuries. There are clues as to what is artifact and what is not. Appleby in 1993 published 44% of patients investigated for dissections having an ascending linear artifact and more than 80% having a mirror image in the descending thoracic aorta. More recently, 2001, Frenchman Vignon, he published 23% with linear artifact. And I think the difference between the two is possibly between biplane and multiplane imaging, but also the Vignon paper does not describe artifacts which clearly have nothing to are not reverberation artifacts within the lumen of a linear form, but other types of artifacts which are not even within the lumen. What they also did was they compared artifacts with true intimal flaps, and certain features which were very predictive of artifact were showing similar flow rates on either side of that intimal flap, displacement which is parallel to the aortic wall, and a thickness of greater than 2.5 millimeters, and an angle which abuts the plane of the aorta in a horizontal plane of greater than 85 degrees. So having confirmed the diagnosis, certain other things that we could really do with telling the surgeon. And I would suggest to you that one of the first things we need to know is the urgency of the surgery. Yes, we need to get this done as quickly as we possibly can, really. But signs of impending rupture, any signs of extravasation of blood, such as a pericardial collection with blood in it, pleural collections of blood, and mediastinal collections, which will increase the distance between the probe and the left atrium by more than 1 centimeter, or the probe and the descending thoracic aorta by more than 1 centimeter. If you see that, don't delay, straight into theatre. Aortic root and valve assessment, which I'll come on to. Branch vessel involvement, this is where echo falls down a little bit, certainly compared to CT, which was scanned from the neck to the groins. Locate entry site is helpful for the surgeon, but is certainly not mandatory. And distinguishing true and false lumen, I'll come on to. This is a patient, a man of about 60 years old, who presented fairly classical signs of an aortic dissection. And this is a transgastric inflow-outflow view of his right ventricle, showing not just the pericardial collection, but actually clot forming in there. This guy was actually beginning to tamponade. The tamponade physiology is not evident. There's not diastolic collapse of his right ventricle just yet, but he was in a very bad way indeed. Coronary osteal involvement is another reason for us to be getting on with this, and this is going to occur in about 10 to 15% of cases. In the video, you will see the flap, which is around about between right and non-coronary cusps on the short axis there, covering the commissure between the two. And on this particular patient, who was in his early 40s, this actually dissected into his right coronary osteal, and he infarcted his right ventricle. He was lucky to survive. I think he was with us for about 2 or 3 months in the cardiac intensive care. Similar image. I don't know if you can actually see that, but as you can see at the very bottom there, the right coronary ostium has only just been spared. It might have been helpful to put color on this, and we would have seen color flowing down there. Short or long axis views. I think what is probably better is actually seeing regional wall motion abnormalities on assessment of LV function, rather than actually trying to find the exact plane of the coronaries, particularly for the right. We know that is quite difficult to do. Coronary obstruction occurs in between 10 and 20%. This particular paper from Neri, 11% are obstructed by the flap, mainly on the right, if not then both. The left very much less so. But bear in mind that an awful lot of patients who are having aortic dissections have got coronary artery disease and have got other good reasons to have ischemia. Ischemic ECG does not mean we've got osteal involvement from the flap. It's readily diagnosed on TOE, is an indication for immediate surgery, and that dissection into the coronary arteries is potentially repairable. Some of the work that is published by surgeons who do a couple of aortic valve repairs before breakfast and then go to work, they will take those on. They will do that. I suspect many of the cardiothoracic surgeons certainly working in this country would be unhappy to do that, and it's more likely that the whole lot's going to go in the bin. Aortic regurgitation in acute dissection. Now, this is something where TOE really stands above CT and probably MR, possibly MR. Roughly 50% of patients with type A dissections are going to have significant, that is at least moderate, aortic regurgitation. And about 3/4 of those patients are going to have aortic regurgitation with intrinsically normal leaflets. Of these, most of them are going to be repairable with excellent results by surgeons who are keen to do it, who are doing plenty of it. Note also that even in patients who don't have significant AR, who've got mild AR, some of them are going to have, their degree of AR can be misleading. They will have disease in the aortic root, but in fact the intimal flap is prolapsing into the aortic valve and making that degree of AR. It's very, very short-lived in diastole because the flap can actually prevent it occurring throughout diastole. And in this series by Mosevitz from Boston, they actually repaired 10% of their aortic valves in acute type A dissections, which the AR was thought to be insignificant. This first one I have here, clearly we have a dissection flap from the sinotubular junction anteriorly, and it's showing restriction there of the right coronary cusp. But on the screen I have in front of me, I can see that quite clearly, and you can actually see the attachment from the right coronary cusp to the SDJ, which is preventing complete closure. It is restricting it. Different patient, similar problem. The dissection flap is above the valve, comes down to perhaps just below the sinotubular junctions, and we have restriction of both leaflets and a central broad jet of central aortic regurgitation. Turn out on its side, here we have a short axis view, and there you can see that any dilatation, in particular that sinotubular junction, is going to move the commissures outwards radially and going to prevent coaptation of the leaflets centrally. The mechanism is quite clear, and there we have a central jet of aortic regurgitation. Diagram to show you the same. Sorry, I had a section to show you the same. I think even in a short axis horizontal slice there, you can see that the three-dimensional structure of the valve, the commissures are very much elevated in position above the root of the aortic valve, above the annulus of the aortic valve, and any stretching of that annulus is just going to pull the commissures and the leaflets apart, preventing coaptation, as is the case in that particular one. On the right, we've got a congenitally bicuspid valve there with the true anterior-posterior leaflets and a raphe at the anteriorly there as well. That is not a valve to repair an acute dissection. That goes in the bin. Patients who have connective tissue disease, Marfan, so forth, they also will not have root-sparing, valve-sparing operations. They are likely to have later problems. Those valves go in the bin. 5-chamber view, aortic root with the flaps prolapsing into the leaflet. And this is an example of one where we actually have restriction of the aortic leaflets, but the flap prolapsing into that coaptation deficit renders the aortic regurgitation very short indeed. And this is a valve which will continue to regurgitate if the surgeon just replaces the ascending aorta. This needs work on the aortic valve. Either most likely a repair, if not, it goes in the bin and a replacement. Another one of the same. I think that's quite clear. It's just about getting there. Another long axis view of the aortic root. Here you see the dissection flap. It's actually torn right down virtually into the base of the leaflet. That has resulted in prolapse of that leaflet, probably the non-coronary cusp, and an eccentric jet of AR. Mostowitz paper actually categorizes these modes of aortic regurgitation in acute dissection. That top one is a normal aortic valve. Diagram B there shows sinotubular dilatation and restriction of the valve leaflet, central jet of AR. Diagram C shows the dissection, as that previous video, into the root of the leaflet, which is causing prolapse and eccentric jet of AR. That again can be fixed by a competent surgeon just by resuspending that leaflet. Many surgeons would not. Diagram D at the bottom there is where we have that prolapse leaflet, which is going down through the valve and contributing to the aortic regurgitation. And it may well be that we've got more than one mechanism to the AR at any one time. And it's very important in our examination, prior to patient going on bypass, to be able to tell the surgeon what the mechanism of the AR is, never mind the quantifying just the degree of aortic regurgitation. The intimal tear. Now, we'd all like to be able to tell the surgeon where the entry point is. Depending on which article you read, that will be picked up between 75 and 100% of TE examinations in type A aortic dissections. It can sometimes be seen on 2D. There is some emerging evidence, Donald will correct me if I'm wrong, that on 3D that is easier to find. But I think 2D with color, it's not projected very well, not running very well, that video, but you will often see that little splash of color convergence towards that intimal tear as well, both in short and long axis. You should be able to find, you may well be likely to find that. There is a tear, an entry point right at the very top there. Dissections come right down into virtually to the aortic annulus, and there's a tear right at the very top. True or false lumen? I think this is particularly important. Femoral cannulation. The surgeons, we've got a type A dissection. It's extended all the way through the aorta. The surgeons have decided they're going to cannulate first, go on to bypass. And it is very important to know clearly that aortic cannula is in the true lumen and not the false. And one strategy to do this is actually, whilst we're looking at the descending thoracic aorta, is to ask the perfusionist just to give a quick bolus and watch the microbubbles appear, and be sure that you're in the true lumen. The false lumen is usually the greater of the two, the larger of the two. Here we have descending thoracic long axis views in 2D at the above, and then color below. It's quite clear to see the color towards and then away from the probe on the long axis view. This is a patient who, fairly recently, in November just last year, 60-year-old man with type A dissection. In fact, it was the same guy with the pericardial collection, and it was decided to cannulate and go on to bypass, and I actually induced anesthesia as he was just going on to bypass. And the view at the top is an aortic arch, long axis view at 0 degrees. It's pulse wave, which is in what is the true lumen, and then is the bypass flow and pulse wave below, which confirmed that we were in the true lumen rather than the false. If in doubt, there are a few pointers as to which is which. Certainly the false lumen is usually the larger of the two and collapses in diastole. The true lumen will expand in systole. It is the smaller. Thrombus formation, in particular in the ascending aorta in the true lumen, is rare. In fact, spontaneous echo contrast, thrombus formation is common in the false lumen. It is more common for the dissection to begin anteriorly over the right or over the commissure to the non-coronary cusp, and it then continues up the anterior wall through the greater curvature of the arch into the root of the neck vessels. And thus the true lumen will be on the lesser curvature of the arch. Antegrade systolic flow is clearly the norm in the true lumen, and we could get basically anything in the false lumen being antegrade, retrograde, biphasic, or delayed flow. So, in summary, I would suggest to you, and the guidance from North America would state that transthoracic echo very quickly done in any patient in whom you are suspicious Follow that by, as your institution would dictate, either CT in an unstable patient, a TOE. Be aware of the artifacts I've explained. They're usually quite obvious. There have historically been patients who've had false positives and had the chest opened when it's been in fact due to artifact. I think now that is virtually unheard of. Check for signs of imminent rupture. Pay close attention to the aortic root anatomy, not just the degree of AR, but what the anatomy, what the mechanism of that aortic regurgitation is. Most regurgitant valves are potentially repairable. That's me out of time. Thank you very much.